like to welcome Dr. Leslie Lappalainen. Dr. Lappalainen is a medical lead for addictions medicine at Mental Health and Substance Use Interior Health Authority. She's here today to speak on initiation of Suboxone program in rural emergency departments across Interior Health. So welcome, thank you.
Thank you. Thanks. And I actually just grab my water as well. I think because we're such a small group, maybe I'll introduce myself and then I can find out a bit about kind of you guys and what your backgrounds are, just so I kind of understand the audience, and we'll make it a lot less formal than I had initially planned for. So my name's Leslie. I'm a family doctor and addictions medicine specialist. I work clinically at Kelowna General Hospital as one of the addictions consultants in the hospital. And then kind of my other job is one of the medical leads for addiction medicine. So I was super excited to come here to talk to you about a project that I've been involved with for the last year and a half or almost 2 years now on initiating Suboxone, so one of our kind of main medications that we use to treat opiate use disorder, opiate addiction in all of our emergency room departments in the Interior Health region of BC. And I'm kind of the person speaking about this project, but there was a whole team of people involved in the project who are listed on this first slide. So because it's such a small group, like maybe everyone could introduce themselves just so I know kind of what your backgrounds are and a bit about you. And then we can make it quite informal, so if you have questions as I'm going through, I'm happy to just stop and make it a bit more conversational. Do you want to start kind of over here and we'll just go around? Do you like,
sorry.
No, that's okay. Do you want to just quickly introduce yourself?
Oh yeah, sure. So is Roberta Joseph, Toronto Gin, Dawson City Gin. I'm Roberta Joseph, the chief of the Toronto Gin in Dawson City. Nice to be here.
Nice to welcome. Thank you.
Hey, I'm Bryant. I'm a family physician in town. I work at the Opioid Treatment Services program, which is sort of the main program that provides out in the territory. I trained in Kelowna.
Oh, no way.
A resident that graduated in 2013.
Oh, cool.
Yeah, and addiction medicine and mental health care is sort of a big part of the work that I'm doing now.
Welcome.
My name's Andrea. I'm a psychiatric nurse and I'm a manager for mental wellness and substance use services.
Awesome. We're just doing very quick introductions.
Okay, my name is Carol Shorty. I'm a residential school survivor, and I work at the Qualitative Health Center as a support outreach support worker.
Welcome.
Hi, I'm Amber, and I'm an RN that works at Whitehorse General Hospital. My current role is clinical support worker for our new mental health unit that's being built in the hospital, so we're trying to look at our current state and future state and what changes we can make. So there's a lot of, of course there's a team of us as well that are working on this project, and we're feeling really hopeful about what it will lead to and what the results will be, and see a better therapeutic space for our patients.
Hi, I'm Lynette. I'm just with the project team for the Oklahoma Summit.
Okay, wonderful. Well, welcome. So I just wanted to gratefully acknowledge that I'm a guest on this beautiful traditional territory of the Lappalainen First Nation and to Onquatchin Council. And I'd also like to acknowledge that I'm privileged to live and work on the land of the Okanagan Silk Nation. So this is a photo of where my home is. I don't have any disclosures as it pertains to this presentation. So first, when someone has a heart attack, they present to the emerge and we rapidly initiate kind of life-saving treatment. And then when they're discharged from hospital, we ensure that they have follow-up in the community. And we do all this because we know that it improves their morbidity and mortality. And then when individuals with the opiate use disorder present to the emerge, we really don't do any of those things. So we often don't initiate treatment, even though these people are at exceedingly high risk of death. So I have a question for you, is what if we treated individuals with opiate use disorder in the ER with the same urgency as we do heart attacks or other life-threatening conditions? So in the next kind of 45-ish minutes, I'll take you on a little bit of a journey. So I'll review the overdose emergency in BC just to kind of contextualize my talk. And then we'll talk a bit about kind of our first-line treatments for opiate use disorder and how the province in BC has responded to the overdose emergency. And then we'll talk a little bit about the evidence for using Suboxone in the emergency room. And then I'm just going to tell you a little bit about kind of the struggles of initiating this project that we undertook to start Suboxone in all 29 of our emergency room departments across the health authority, and then a bit about our results to date, and then just lots of time for questions. And again, because it's such a small group, like if you have questions kind of as we're going, just jump in. So just again to kind of set the stage of the drug poisoning crisis in British Columbia, Perry Kendall, who was our former provincial health officer in BC, declared a public health emergency in the spring of 2016. And as many of you know with COVID, when a public health emergency is declared, it allows us to kind of mobilize resources much more rapidly than we would be able to kind of without having declared a public health emergency. It also allows us to collect data in a much more kind of aggressive and extensive way, so we could determine kind of where people were overdosing and the circumstances around it a bit better, and that helped to inform our response. And I understand that the government here in the Yukon also declared a substance use health emergency in January of this year. So this graph shows the overall number of overdose deaths in BC. So you can see number of deaths here, time and years, so from 1996 up to the data that we have for 2022. And then the mortality rate is on the far side on your right. And you can see kind of throughout the 90s and early 2000s, there was a fairly steady rate of overdoses occurring in the province. And then around 2015, you really start to see this kind of uptick. So that's when the public health emergency was first declared in 2016. And we actually see that things got a bit worse in the preceding years. So the overdose death rate had actually gone up. By 2019, we see that things had started to come down a little bit, which was encouraging. But then the COVID pandemic was declared, and that really interrupted a lot of our usual kind of drug supply chains and really changed the drug scene in the province and resulted in a much more toxic drug scene with higher rates of fentanyl and benzodiazepines and other medications, drugs introduced, which again has actually worsened the overdose rate in the province. The mortality rate in 2021 that I was able to find for the Yukon actually is higher than that in BC. So I think it's important that this conference is being held to try and bring people together to try and start to find solutions on how we can start to bring down these overdose death rates. And I believe that this number in the Yukon was the highest in the country in 2021. Since 2020, with the interruptions with COVID and the drug supply, we've really seen an increase in kind of really high levels of fentanyl, and so overall the percentage of kind of samples of kind of the amount of fentanyl is much higher, and that's been trending upwards in the last couple of years. And then we've also seen so benzodiazepines, which are kind of medications used to treat severe anxiety, like lorazepam, diazepam, have been mixed into the drug supply as primarily kind of different benzos. One called Atizolam is quite common that's being mixed in the drug supply. In 2020, it was probably about 15% of deaths that occurred had benzodiazepines present. And by 2021, it was about 50%. So it's is really quite significant now, and we know that benzodiazepines and opiates, they're both depressant medications, and so when combined, they can act synergistically and increase risk of death further. So it's a really, really dangerous drug supply right now. This slide is just to show it's not a Vancouver problem, and so I think that a lot of times there's a perception that this is mainly in the downtown east side of Vancouver, but what this slide shows is that in all the health authorities in British Columbia, there's actually a fairly consistent trend in overdose death rates, and so it's not exclusive to Vancouver, it's across the province. And we now know that the number of people dying per day has actually gone up from 3 people a day in 2016 when the emergency was first declared to 6 people a day over the last couple of years. And drug toxicity is now the second leading cause of death, of potential years of life lost in our province, in British Columbia, with the median age of death being very young, so 44 years. Okay, so I've given you a lot of information. So what do we do with all this? So it seems kind of like doom and gloom. So what are our next steps to try to kind of prevent some of these overdose deaths? So in British Columbia, the kind of 3 main things that the province has focused on is improving access to what's called opiate agonist therapy, or OAT. So this is 3 main medications that are used to treat opiate use disorder or opiate addiction. And so the first one is Suboxone, or the other name for it is buprenorphine naloxone. So it's a tablet that goes under the tongue. It's generally taken once a day. And usually people go kind of once a week to a pharmacy and pick up a 1-week supply. The other medications are methadone and slow-release oral morphine, or Cadian. And those medications typically are what are called daily witnessed ingestion, so you would go to the pharmacy every day for them. All 3 of these medications are very effective in terms of mortality protection. So when people are on these medications at adequate doses, it really protects them against dying of an overdose. So if they used fentanyl or heroin on top while they're on these medications, it helps protect them against overdose. And these are really kind of the mainstay of treatment for opiate use disorder in terms of helping people not use or use less. And provides overdose protection, as I mentioned. So this kind of lever is going to be the main kind of focus of my talk today. The other kind of key initiatives that the province has focused on are increasing access to supervised consumption services. So whether that's like a supervised consumption site that has gone through the process of getting a formal Health Canada approval, or also overdose prevention sites, so which are kind of more informal supervision in shelters or low threshold housing units, and then increased access to take home naloxone kits. So those are kind of like the 3 main buckets. And then there's a bunch of other initiatives that have also been undertaking. So increased bed-based services, so like what we consider as treatment beds, increasing access to substance use counseling, drug checking, so having like test strips for fentanyl and benzos, injectable opiate agonist therapy, safer supply or safer alternative prescribing is kind of a recent focus in the last couple of years. Decriminalization, so the BC government announced that starting end of June of 2023, they're decriminalizing possession up to 2.5 grams per person. And then there's something called the Lifeguard app, which is an app for people who use drugs alone. That if essentially it has a little timer, you use drugs and then you hit, I'm okay. And if you don't hit it, an alarm sounds. And then if you still don't hit it, the alarm gets louder. And if you still don't hit it, paramedics are sent to your location based on the GPS of your phone. So we know, or GPS on your phone. We know that a lot of people dying in the province are people who are using alone, and some of these people, as a result of stigma, are less likely to access supervised consumption sites. And so we're trying to think of like what are innovative ways to try and target people using alone. So the Lifeguard app is kind of one of those strategies. It's not perfect, particularly in rural, remote areas where there may not be really good cell phone access, or paramedics may be really far away, but it is one intervention that is working well in some communities. This is an interesting study that was done by Irvine and colleagues that used mathematical modeling to determine the number of deaths averted as a result of OAT, supervised consumption, and take-home naloxone. And what they found was that overdose deaths in the province would actually be 2.5 times higher if we hadn't implemented those 3 kind of main interventions. So my talk, for kind of the rest of the talk, is going to focus really on this circle, really looking at Suboxone, which is in the BC provincial guidelines as well as the national guidelines, the preferred kind of first-line treatment because of its safety profile. So to become a prescriber in British Columbia, prior to the public health emergency being declared, it was kind of a high barrier system. So there was a course in Vancouver, largely in Vancouver, that was held a couple of times a year. And then once you did the course, you would do a preceptorship. And so for like physicians or nurse practitioners, if you wanted to become a prescriber, you had to travel to Vancouver, pay for accommodations, and then potentially travel back to do the preceptorship, because many of the preceptors were largely in the Lower Mainland. So it wasn't super user-friendly for kind of docs not in the Lower Mainland. So in 2017, the BC Centre on Substance Use, or BCCSU, was given responsibility for education and care guidance for prescribing OAT, or medications for opiate use disorder. They kind of totally changed the approach, so it was an online course that's free and self-paced, so you can do it kind of when you want, and it's CME accredited, and so nurse practitioners or physicians could get continuing medical education credits. And then there's still a workbook that you would complete after, and an in-person preceptorship, but they really tried to kind of broaden the preceptor base so that there were preceptors all over the province, not just kind of in the Lower Mainland. And then in September of 2020, the provincial health officer gave a public health order to authorize RNs and RPNs to prescribe medications for opiate use disorder. So the initial phase of this was prescribing Suboxone. And then phase 2 has been to prescribe methadone and slow-release oral morphine, but in a kind of limited scope, and so usually in conjunction with a physician or a nurse practitioner. So they would do continuations, titrations, and restarts, but not initiations, and there's kind of a max dose for prescribing, and then clear kind of escalation pathways. So that's kind of the changes in terms of prescribing, and I would say overall has been fairly successful in terms of increasing the number of OAT prescribers. So this is provincial data based on it's called PharmaNet, so it's like essentially online repository of any medication that's dispensed, and it has a prescriber. So any medication dispensed in a community pharmacy, not acute care. And I really just want to draw your attention to this top line. So that's any form of OAT. And so in 2015, there was approximately 500, a little less, OAT prescribers in the province. And by 2022, there's over 1,800 prescribers. So significant increase. This is largely a result of people prescribing Suboxone. But you can see this kind of blue line here is methadone prescribers, and you can see it has about doubled methadone prescribers. And that's probably more reflective of people that prescribe OAT on an ongoing basis, whereas some of the Suboxone prescriptions may be kind of just one-off prescriptions. We've also seen that there's been a general kind of upward trend in the number of patients on OAT. So from about 15,000 in 2015 up to almost 25,000 in 2022. And when we think of the research we know of how protective these medications are for overdose protection, this is all really encouraging. We do know that there remains a significant kind of rural disparity in terms of people accessing OAT in rural regions. So rural is in blue and urban is in green. And so ever on OAT is lower in the rural group. Recently on OAT is lower in the rural group. Currently on OAT and then retained at 12 months and retained at 24 months. And this isn't entirely surprising. So in many urban centers, there's OAT clinics that are open 6 or sometimes 7 days that will accept drop-ins all the time. And so if you want on OAT, you can kind of get on it right away. And then when I think of our health authority, like we have many clinics or many communities rather that have an OAT clinic for maybe half a day every other week. And so if you have someone that wants to go on Suboxone or methadone or Cadian and they're told like, oh, it's going to be a 10-day wait until your appointment, we know we lose people in that time. And so this isn't that surprising, but is evidence that we need to think more creatively of like how do we provide care in rural regions to help people have better outcomes. Despite all this work to improve access to OAT, we know that people don't always come to our offices. And so they do present to the emergency room, at least in British Columbia, quite a bit. So this is a report that was published in March of this year from the BC Coroner's Service that showed the majority of decedents, or majority of people who had died of overdoses, had recent contact with healthcare professionals prior to their death. In Interior Health, so the region where I work, there was a chart review done over the course of about 2 years. So there were 270 patients, and they looked at, 270 patients who had died of a fatal overdose. And what they found was that 2/3 of those individuals who had died had their final interaction with a healthcare provider in the emergency room. And of those, 1/3 was within 14 days of their death. So to me, this really speaks of like, we are missing a huge opportunity to engage people in care. And these are people that are really, really, really high risk of death. There's lots of evidence now on ER-initiated Suboxone. So this was kind of a big trial that was published in JAMA, which is one of the biggest journals, medical journals in the world, in 2015. And so what it showed was that when we initiated people on Suboxone in the emergency room, their retention in addictions care is doubled compared to just referring them to treatment. So compared to saying like, oh, just follow up at this clinic, if we start them in that moment, they're much more likely to stay in care. Since this big trial was published, there's been a number of other trials that have shown that ER-initiated Suboxone has resulted in quite good retention in treatment, so between kind of 40 to 75%, which is actually really quite good retention. So in my role as a medical lead for addiction, I'm like, okay, and I work in acute care, I'm like, how do we make this happen in more rural areas? Because a lot of these studies are like big urban centers. So this is the region where I work. The population's about 725,000 people. There's 4 kind of primary larger centers, so the communities of Kelowna, Kamloops, Penticton, and Vernon. And then otherwise the region's fairly kind of geographically dispersed with a number of small rural and remote communities across the region. So it's a pretty big geographical area. Prior to this project, we had in our larger centers, so Kelowna, Kamloops, Vernon, Penticton, 4 different Suboxone. This Buke NLX is Suboxone, just to make it confusing on my slides. So we had 4 different Suboxone pre-printed order sets, and they were all kind of different with like slightly different protocols, and there were a bunch of barriers to utilizing them. So when we start people on Suboxone kind of like traditionally, we start it when people are in withdrawal. So it has to be kind of 12 to 24 hours since their last use of any opiates like heroin or fentanyl. And so often when people came into the emerge, they maybe had used four hours ago. And so they weren't in enough withdrawal to start the medication in that moment. And so they ended up being discharged. So that was one of the barriers. I'm not sure, do you guys have like duplicate or special prescription pads for OAT or opiates here?
We don't anymore.
Okay, so that would not be a barrier here, but in BC they have like a special prescription pad where you have to write any opiate prescription or any OAT prescription, and a lot of emerge docs don't carry those around. So that is also a barrier, just actually physically writing the prescription doesn't get done that often. And then getting to the pharmacy and medication coverage is another piece that was a barrier with our previous PPO. So if you could imagine someone is given a prescription at midnight and then their pharmacy is not open until 9 a.m. That time period that elapses can be too long for people, and then they're like, no, this withdrawal is too bad, I can't do this, and then if they use, then they can't start this Suboxone. Yeah.
How expensive is it?
Yeah, good question. So it depends on the dose and the amount that you prescribe. In BC, to make it more confusing, the 8 milligram tablets and the 2 milligram tablets are around the same cost. With the dispensing fee, it's often about $20 a day. So it's not cheap. In BC, since the public health emergency has been declared, they've really changed things, so it's really easy to access free coverage. So there's a form called Plan G that we can sign that essentially just says this patient can't afford this medication and they're at risk of harm if they don't get it. So almost everyone would get approved for Plan G. It's technically supposed to be if they make $45,000 a year or less, but you could get pretty much everyone approved for it. So it's essentially free, but it involves filling out a form and faxing it, which in the emerge is a barrier that it just like doesn't happen. And that was when we started this project, the emerge docs are like, we're not doing Plan G for it. So it was a hard no. So those things are a barrier. I'm not sure about coverage here. Is coverage an issue for Suboxone?
In the emerge a little bit.
Mm-hmm.
We have broad coverage for Suboxone, like NIHP covers it for a lot of our patients, and then social assistance offers funding for all of the OAT options, even if someone's not on social assistance. But to get a card for that, it's really, they have to connect with our clinic. So our emerge docs often give like a Suboxone take-home covering order a couple days, and then connect with the clinic.
Gotcha. That's a good strategy, because it like if someone gets to a pharmacy and they're faced with a bill of $20 or $40, like for many patients are like, forget it, not doing it. It's just 5 drugs. So these treatments should be covered fully. So in BC, certainly medication coverage can be an issue. Usually it's a pretty easy fix, but out of the emerge, it can be a more challenging fix. And then, as I mentioned, the kind of barrier to follow-up was a big one. So particularly when I started thinking about like how do we roll this out in smaller communities, emerge physicians would need to write prescriptions for like potentially 2 weeks if they didn't have OAT clinics on a regular basis, like it was every 2 weeks and you just missed that clinic. You'd have to write a long bridging prescription, which I think many emerge physicians would be hesitant to do. So we did have some enthusiasm from both our ED network and our substance use network that we could improve what we were currently doing. We were quite fortunate that our ED network director came from Alberta Health Services, and they had launched a Suboxone in the ED initiative. And they were really lucky, like they had this beautiful, Alberta Health Services has this beautiful virtual OAT clinic. So they just sent all their patients to that clinic, and it was already well established. It's like a really robust provincial virtual service. And so they just sent all their Suboxone starts from their emerge to that service. And we also met with some colleagues in Vancouver who were doing this Suboxone to go kits. So a 72-hour supply of Suboxone, because they knew that, again, for some patients to go to a pharmacy was just such a barrier. And so these ideas were kind of percolating of like, okay, here's a couple different models. We talked to some pharmacy colleagues who got very clear direction from the College of Pharmacists in BC that 72 hours was like the absolute maximum you could give. And I was like, can we give 2 kits or 3 kits? And they were like, no, like just 1 kit, and it can only be a 72-hour supply. So this was me, and I was kind of like spinning in terms of how I was gonna overcome this. Like we don't have a virtual service. It's not feasible to get OAT clinics every 72 hours to kind of fix this. So this is kind of what we did to try and problem solve this. Our ED network, and it sounds like it's quite similar here, is very siloed from MHSU, and acute care and outpatient care are also quite separate by the sounds of it, at least some of it. So we were all working in our silos, and this project really forced us to work together. We're maybe fortunate in that we do have funding that is not as separate as maybe it is here. So we were able to secure funding for a project lead, a transformational nurse lead, and then we had physician champions who were kind of like geographic in our health authority. So they led the physician education for kind of the EDs in their geographical area. And then we had people with lived or living experience kind of provide input for the pathway and kind of what this would look like from a patient experience. And then we also had pharmacy representation, nurse prescribers, and kind of evaluation folks involved fairly early on. So what we were able to do is kind of bring these people together to develop a steering committee, and then developed an order set. And we started to bridge some of these silos that have existed. So we developed a pre-printed order set that was regional, so the same in kind of all of the emergency rooms. And we had a 72-hour Suboxone to-go kit. And then we developed 2 pathways. One was a ED induction pathway, and one was a home induction pathway. So for the ED induction, if someone was in withdrawal and were kind of ready to start Suboxone in that moment, they could be started on that pathway. And if someone came in and they had a cellulitis or some other thing and were in the emergency room, they were identified as having an opiate use disorder, but they were going to be discharged, they could be given this like home induction pathway. So they could still get the vial of Suboxone to start at home. So they were given patient education, so written materials, as well as a link to a video on how to do a home induction at home, or how to continue an induction if they had been started in the ED. And then we had a centralized referral that went to this new virtual service that we established, run by nurse prescribers, so RNs or RPNs prescribing Suboxone. Our rollout at each site was quite gradual, and we had our nurse educator go to each site and provide the nursing education, which was a pretty big task for her. And then our physician education was led by, we had 5 physician champions.
Can I interrupt just a
Yeah,
second? Was
of
that
course.
pretty difficult, like with the nature of ER staff and like nobody being on at the same time? Is that why it was so many visits? Like, is that why it was so onerous?
It took a while. Well, it's a big area, I mean, as it is here. So like it was a lot of travel for her, and then exactly like to try and capture getting the majority of the nurses to provide that education is hard just with shift schedule to like try and capture that. So you'd have to repeat your education sessions quite a few times. And even still, like you would still miss. You're not gonna get everyone. And so part of our kind of long-term sustainability plan is like going back and repeating a lot of the education, just because people, they either hear it once and forget it, or they were never really exposed to it, so they're just like, oh, I see this.
Or what about like
Order
video?
set.
Was it ever?
Yeah, it was recorded, but I think there, at least in our health authority, there's a lot of like, they're called I-learns. And so there's a lot of mandatory I-learns, and I think that they sometimes get done quickly
Yeah.
to check the box,
Okay.
without always, yeah. So sometimes in person is better where possible, but I think recorded is a good alternative, especially in a pinch, like if you're like, okay, I'm giving this PPO or this vial of Suboxone right now, and I need like the 5-minute version of what do I need to teach the patient, then a video is
Because even new staff
sufficient.
coming on, but, or like training a champion within that department.
Totally,
Okay.
yeah. This, so how we kind of overcame the follow-up barrier is we established a new service that was a kind of centralized, so any patient that was started at any of the emerged departments, they were all referred to the centralized urgent OAT service. And essentially the MOA would receive the referral, they would look at where the patient was from, and if they could book them follow-up in 72 hours in their home community at their local OAT clinic, they would book that. And if they weren't able to be followed up within 72 hours, then they would be booked in with this virtual service who would kind of check in with them, see how it was going, and then write a bridging prescription until they could be seen in their home community. The prescribing was all done by nurse prescribers, so RNs or RPNs, and was staffed 6 days a week. And then this is just kind of a map of all the sites where we've rolled it out. So it started June 15th of 2021, and we got our last site live kind of end of August 2022. So it was a 14-15 month process to get all the sites up and going. We staggered the rollout for a couple of reasons, mainly in terms of just making sure the education went out smoothly, but also to ensure that we could like launch a couple of sites and really learn from it and see what worked well, what isn't working, and then kind of improve on that process. We've had 190 starts as of the end of August, so I think that's actually quite good. You can see that the communities with a larger population are getting more sites. They were also launched earlier than some of the smaller sites. And kind of as expected, as more sites go live, we're seeing kind of a steady increase in the number of starts per month. And about 70% of the starts receive virtual follow-up, and the other 30% were able to be booked in person in their home communities within 72 hours for follow-up. We have a really robust evaluation planned that I was hoping to be able to share, but I don't have the data back yet. So we are getting data from PharmaNet, so our provincial kind of medication dispensing, to look at retention on any form of OAT. So we're looking at 14 days, 30 days, 90 days, and 180 days after ED discharge. And it's any form of OAT. So if they were started on Suboxone and then switched to Acadian or switched to methadone, we would still call that a OAT retention. And so we're hoping to have, like, the data's like this close to coming, I'm told. So I was hoping I'd have it, but I don't have it yet. We also did a qualitative evaluation component. So we had 4 unique surveys sent to patients who used the service, ED providers, both nurses and physicians, pharmacy dispensing staff, and then an OAT provider survey. And then we did focus groups with the virtual nurses to see kind of what their experience was. Overall, the provider experience showed that they considered Suboxone to be an evidence-based intervention, and that the emergency department was an appropriate environment to start people on Suboxone. But there were a number of barriers. It was noted that the ER environment is often busy and complex, and that starting Suboxone was felt to be really time and resource intensive, and that I think there was just some discomfort that they weren't seeing patients started on this pathway all that often, so there was a lack of confidence in terms of prescribing it. There was also a perception that there was a lack of follow-up for patients. So I think to me that this feedback speaks to the need for kind of ongoing feedback around, like, actually people are doing quite well on this. Hopefully we'll have that retention data that we can give feedback back to the emergency room providers on like, hey, you started this patient on Suboxone and they're doing great. So more than half of the inductions were actually home inductions, and so those are actually quite quick to do the home induction, so it's maybe not quite as time and resource intensive as we think. And of the ED inductions, most people only had 2 doses in the emerge, so usually you would give an initial dose, about an hour later give the second dose. So again, it's not like they're staying in the emerge for 10 or 12 hours. It's actually still fairly close. And then the patient experience, I think this is like the best part hearing about this. So almost 90% of people who were interviewed and responded to the survey and were started on Suboxone would not have started it if they weren't offered it in the ED, which is huge. And so if we think of like how life-saving these medications are in terms of overdose protection, it just speaks to like we need to really have these medications accessible in a variety of settings and offer it to patients. And again, to me, speaks to like that missed opportunity to intervene and how many people are dying who had recently been in emerge. And then here are some just direct quotes that really, I think, speak to the impact this program has had on patients' lives. So the doctor was wonderful. I felt very relieved to have an option to escape addiction. I'm so grateful. Suboxone is life-changing. I went from injecting to just taking Suboxone every day. I'm starting to get my life back together finally. I'm very excited. My personal opinion is Suboxone should be easier to get than street drugs, and this would help people who use drugs looking for other options. So overall, really like quite positive feedback. Sustainability, so I kind of touched on a little bit of this. We're looking at, on a monthly basis, how many new starts there are by facility, and then we're going back and doing ongoing education at one site per month, just to kind of repeat. And then we've incorporated opiate use disorder and OAT education into nursing education for new nurses in the ED, as well as every nurse if they orient to a new site. And then again, as I mentioned on the previous slide, that I think there's a huge role just to provide feedback to ED providers around our kind of retention data and what's working well with this project, because I think there's a perception that maybe it's not effective, and if people know that it is working, I think they're more likely to want to give people kits. We've recognized there's a need for kind of ongoing education for ED nurses and physicians on opiate use disorder, as well as like as a physician that works in acute care, anti-stigma education more broadly, and certainly I've felt that as a theme throughout the talks thus far. There's also some momentum from this work, so we're looking at launching a similar project at all of our urgent primary care centers. So to have Suboxone starts at every urgent primary care center, and then we're also just starting a project on approaches for alcohol use disorder in our emergency room, because we know that's also something where we could definitely improve our management. So that's all I have prepared. I'm happy to answer any questions, and thank you for listening. If there's any questions? Yeah.
What is the average length of stay for somebody who's having an ED induction?
That's a good question. I don't have like the exact time frame, but I think that is something that our evaluation committee is kind of looking at, because I know certainly like from the ED network perspective, like that data that they care a lot about, is it a 2-hour stay or is it a 10-hour stay, and they're always looking to kind of improve efficiencies, but I don't have that data right now. But if I get it, I can get it to you, because I think that's also compelling for emerge providers to find out like how short is it, at least in our emerges. Yeah.
Yes, ma'am.
Yeah, of course.
Are the takeaway Suboxone prescriptions, are they already kind of pre-bottled up and the physician just hands it to the patient or orders it, or?
Yeah, it's just in a vial in our Omnicell. So in all the sites that have Omnicell, it's like a vial already. So it's all 2 milligram tablets, and then there's enough for 12 milligrams on day 1, and then 16 on day 2, and 16 on day 3. If I could do the whole project again, I would probably also do the option of like a microinjection blister pack. Like that would have been my preferred. So we have a couple ways to start people on Suboxone. One way is called a microinjection, where you start people like really slowly and they don't have to be in withdrawal. So if I could have, I would have really pushed for the microinjection option as well, because I think it's now, at least in BC, kind of the preferred way of starting people. There was a lot of hesitancy from the Emerge perspective to pursue that because there isn't a lot of literature on microinjections out of the ER, whereas there is a lot of literature for like conventional starts. So they were like, we don't have data around that, so let's not do that. But the Vancouver group is now doing a clinical trial to look at microinjections, and I think that they have a site or two in Vancouver and then a site in Edmonton where they're doing this clinical trial to look at microinjections versus traditional. So maybe once we have that data, then I can convince my colleagues to do a microinjection pathway. Yeah.
So this Suboxone,
Yeah.
does that help you get off of the drugs?
Mm-hmm. So it acts on the opiate receptor. So it kind of like binds to the opiate receptor and in some ways blocks the effect of other opiates. And so if the individual, while they're on Suboxone, if they used heroin or fentanyl on top, it's hard for the heroin or fentanyl to bind to the opiate receptor, and so it provides overdose protection, which is really key, especially in the current drug scene. But it also helps with cravings for opiates. So essentially all the medications that we use to treat opiate addiction are medications that act on the opiate receptor and kind of bind to it to a certain degree to get steady state blood levels, so people aren't feeling like they use and then it wears off and they're in withdrawal and they just feel so crummy and terrible, and then they have to use again just to feel kind of normal. So these medications are all act on that opiate receptor but get their blood levels kind of steady, so they're not on that roller coaster of withdrawal and then using just to kind of feel normal.
So do they get go on this medication, like regular medication, and stay on it for a while?
Yeah, great question. Yeah, that's the usual approach. So it depends a bit on the person, but usually we suggest that people be on kind of minimum 6 to 12 months and then a really gradual taper off. And the reason is if we put people on these medications really quickly, like we put them on for a week and then we taper them off right away, their relapse rates are really high. So it's kind of upwards of 95% if we just taper them off right away. And so generally we put people on a dose where they feel comfortable and they're not having cravings and they're doing well, and keep them on that dose for a while. And kind of the hope is in that time, if it's within their goals, that they're able to kind of stabilize other parts of their lives as well. So like they don't have housing, get housing, or go back to work or go to school, those types of things, and then really gradually taper off.
So that even helps with a chronic, a chronic person who's a drug addict.
It's very specific to opiate addiction, so it doesn't work for crystal meth or cocaine addiction, but for opiate addiction, it's kind of our main treatment. And things like you would think like, oh, could I just put someone who has opiate addiction, like send them to like a detox center and they just kind of get off all the opiates, then they'll be okay. But the research is like, it doesn't work. So it's upwards of kind of 95% of people will relapse if we just detox them. And they're actually at higher risk of death because we take away their tolerance when they're, say they are admitted to acute care, and if we don't manage their opiate addiction while they're in acute care, they lose their tolerance and then they're discharged from hospital and then they're at high risk of death. Same with like if someone's incarcerated, that period of time right after incarceration, if they're not started on treatment, is it increases the risk of overdose.
So they need to find something for the other drugs.
Mm-hmm. If you find something for crystal meth, please tell me, because it's where I practice. It's a tricky one to know how to manage, and we don't have a lot of research around really good medication options for crystal meth.
So for someone who does opioids,
Yeah.
like if there was none of that stuff around and they didn't have this Suboxone, what do you call it?
Yeah, you said it absolutely right.
They could switch, right? Just to get that high, or
They
some
could-
sort of high,
They could switch to what?
to the other stuff that you're talking about.
They could switch to like methadone or,
Methadone.
yeah, exactly. So for some people, especially with the drug scene the way it is right now, some people just don't stabilize on Suboxone. So we get them on like the highest dose of Suboxone and they're like, I'm still having cravings or I'm still using a lot, it's just not working. In which case we would switch them to the other treatment option. So methadone is a drug that's been around for 50 more years and is really good. It's a good medication option, but it's kind of complicated. So it interacts with a number of other medications, and so we have to be really cautious in the way that we prescribe it. And Cadian or slow release oral morphine is also a good option, but it's newer. So we're just kind of developing more comfort in prescribing it and creating kind of more research around how good it works compared to methadone. So it's a newer treatment option. But both are quite effective and provide good overdose protection. The other thing is all the other benefits that come from being on these medications is like regular check-ins with a healthcare provider. So like seeing a doctor or nurse practitioner on a regular basis. If someone's on methadone or Cadian, like they go to the pharmacy frequently, so seeing a pharmacist regularly, and just having all those like opportunities to check in, and also work on like other things that are going on with their kind of overall health. So like having routine blood work done if they have HIV or hepatitis C, like getting treatment, working with a social worker to like get housing, or like all those other types of things that we know are important for someone's like overall health. That a medication alone isn't the answer for. We need like a much more kind of robust picture. Does that make sense?
Yeah.
Yeah.
It does.
Any other questions about it? No.
I got lots of questions. It's a tough one, I don't know.
Yeah.
So has this decreased the opioid deaths in BC?
Our program in particular?
Yeah.
I don't know. Is the simple answer is I don't know the exact impact of like our individual program. We do know, let me just go back. The overall OAT provision, I'm just gonna go back to this slide. This is, okay, there it is. This is somewhat imperfect data because it's mathematical modeling, but essentially these are the number of deaths that they observed, and this study tried to look at like these different kind of interventions, what was the impact in terms of decreasing mortality. And so by far, like take home naloxone kits are one of the best interventions we have to like prevent people from dying. Supervised consumption is a good start, but it's not perfect, and I think that kind of makes sense because we don't have supervised consumption sites 24/7 in all communities, and not everyone feels comfortable going to supervised consumption sites. OAT in this study is all grouped together, so it's Suboxone, methadone, and Cadian kind of all group together, but it is preventing a lot of deaths. In BC, the coroner service releases data, when they do coroner reviews for any overdose death that occurs, they look at like what drugs were in the person's system, and Suboxone is the most protected. So there's very few people who die from overdoses that have Suboxone in their system, and it's something about it's less than 5%. So it is very, very protective against overdose, probably more so than methadone and Cadian, but it's not the perfect medication for every person, and so it's a good option. But for some people, they're like, nope, tried Suboxone, didn't work, or there's something called precipitated withdrawal. So if we give Suboxone to individuals too early, it can make them feel worse instead of making them feel better. And often if that experience has happened to a person, they're like, I'm never going on that drug again because I felt so terrible. So we kind of use it as a treatment option if that happens. So I don't have exact data in terms of like how many lives are saved as a result of this project, but overall starting OAT is a life-saving intervention.
I have another question.
Of course.
Is the nasal naloxone commonly used?
I'd say not in BC. So it's available through our First Nations Health Authority, and RCMP have it, but otherwise in the rest of the province, it's by and large the injectable naloxone. It's not readily available. I think it's more expensive, but I don't actually know the cost difference between the two.
Is there a way because BC has an emergency, is there a way for using that rather than the other
Rather
than the needles? Because to me, I just find that having the needles is another avenue for pushing the already vulnerable into a much more addictive, a much more further addiction through needle injections, you know.
Right.
And I just think that that has become much more severe since naloxone has been, the needle naloxone has been provided here.
Gotcha.
In the Yukon, but
So people are using the needles to inject from the naloxone kits?
yeah.
Yeah, it's an interesting
Because-
question. I mean, I'm hearing your experiences, like if we provide more needles, then people are more likely to inject. But I'm unsure as to whether people may inject either way. And if we have, like, ideally, if people are going to inject, we have needles so that they're not reusing them. And so I think if we don't have needles, it's not going to necessarily deter people from injecting. They're just going to inject and like share needles, and then they're more likely to acquire things like hepatitis C or HIV. So I think there's probably a role for both, of like having both the intranasal naloxone kits, and I think the cost is a pretty big difference from what I've heard between the intranasal and the injectable, but I don't know the exact cost difference. I don't know if anyone here knows.
I think the reasoning as well too, though, is for using the needle versus the intranasal is the onset times, like how fast it takes it to work. So if you get the needle, you're gonna recover a lot faster, where it takes longer in the intranasal. So they have a better chance of recovery with the needle, like it's the gold standard.
That's not what I heard from the doctor that provided one of those to my brother when he was in his last stages of cancer. He asked him if he wanted a nasal one, or he asked me and my sister if he should provide an naloxone needle or a nasal one, because he was taking fentanyl for the pain, and so he said the nasal one would probably, well, we asked him to explain
Yeah.
the difference, and he said, these are more costly, that's why the nasal one was more costly, that's why they're not issued broadly, but it was covered under NIHD.
Yeah.
So anyways, as opposed to the naloxone, which is easily handed out for free. So I just think that using methods that such as the naloxone needle kit just provides a more push towards having people become more addicted to drugs by needle. And so that's what I'm guessing, and it's just another method of getting rid of the First Nations people, as far as I'm concerned.
Yeah, I'm not an expert in terms of like the Narcan kits, in terms of knowing kind of like
Yeah,
who makes the
but-
decisions around, whether
The thing
it's
is that-
injectable
is
versus
that-
intranasal.
You know, like practitioners can make recommendations to the higher ups, as they work together on this in terms of developing the boat hub. And you know, like I could see that happening here in the Yukon. Like we don't even have access to this kind of information. You know, like in terms of how many people are on opioids. You know,
Yeah.
or how many people are just like in the streets, like how many people are on opioids, or how many people are on crack, you know, or whatever else there is. Crystal meth.
I wonder, and I'm not certain about this, but with the Yukon declaring a public health emergency, like I wonder if that data is going to become more available, because I think a lot of this data is actually available only because the public health emergency was declared in 2016, and so they're collecting all this data to inform our response, but I think it took some time, is my sense.
I don't know if it's broadly known too, but the intranasal naloxone kits are, they are available to anybody who has access to non-insured health.
Yeah, I know, but it should be for everybody because it is declared an emergency here, just as well as during COVID, there was like a lot of things that were provided to the public, like the test kits and different kinds.
Yeah.
And it was all for free, so.
Yeah. Yeah, I think there should be more availability of both, for sure. And certainly in my health authority, like I actually don't know where, West Bank First Nations would be kind of the only place I can think of to send people if they wanted an intranasal kit. And everywhere else that's like a interior health supported clinic, that would dispense kits, it'd all be the kits with the needles in them. So yeah, I recognize there's probably increased need for availability of both types of kits for sure.
Because they're not really being provided here in the Yukon.
Is that right?
And they should be.
Yeah. Yeah, I mean, I think this data speaks to like just the need of like how life-saving this intervention is.
Because it's
do you
much
need kits in
easier to
general?
access. I mean, it's much easier for a person to just take the nasal thing out and use it, right? Instead of like monkeying around with this little container with
Yeah.
naloxone in it and a needle and like.
Yeah, it's a bit more of a barrier. I kind of, when I'm teaching,
And it's too big and bulky to carry around in your pocket, whereas the nasal you can
Is
stuff it
smaller.
around in your pocket.
I haven't actually yet even ever seen a real Narcan, an intranasal Narcan kit.
You see a lot of them.
Do you see them
There's-
here?
There's quite, I work quite a bit at the shelter, and
Yeah.
most people have both types of kits on them actually. They'll
Cool.
have a needle kit and then inhalational. I think there's quite a little bit of kit sharing because you're allowed to just walk into a pharmacy here and get a couple of the intranasal kits, is my understanding. And so
Okay.
I think people who are going in daily for their various medications
Yeah.
are picking up kits and then sort of disseminating them.
Great, which I,
Quite lucky in that I'm sure there's a lot more that can be done, but there, at least for the people who use substances that we see at our clinic, a lot of people seem to have access to
kit.
pretty good
That's quite
supply
rare.
of both types.
We do have to
Yeah, of
kind of wrap,
course,
sorry,
of
we have to
course.
wrap
No,
things up because
no.
the next presenters are
That's
hoping
good.
to get in. But thank you so much. Obviously, probably could have stayed and talked longer, but.
Thank you, 6 people.